Welcome back to MedMythbusters HIV. I'm Rachel Deere with DKB Med. In this third episode, we go a little deeper into HIV and talk about screening, diagnosis, and ART in primary care. Now, I'd like to introduce our fantastic faculty, Asia Sullivan, a certified physician assistant based in Los Angeles, California. Our learning objective is discuss current treatment recommendations for people with HIV who are entering care. Here's Asia.
Thank you, Rachel. The first myth, HIV screening is only necessary for patients who disclose specific high-risk behaviors. This is a myth. The CDC recommends opt-out HIV screening for all adults 13 to 64 years old as part of just routine primary care, regardless of their perceived risk. So anyone of this age who walks through the door, we can at least offer to screen for HIV. And again, when people are offered, they very rarely say no. So this kind of takes the thought process or their perceived risk or your assumptions about their risk out of the equation. We're just going to test everybody. Many people with HIV don't recognize their own risk factors or maybe aren't comfortable disclosing them. And so risk-based screening really perpetuates stigma. It allows us to miss these diagnoses. And again, the main thing we want to do, especially in a primary care perspective, is just normalize routine screening of HIV. And we're going to talk about some of the ways to do that. We should also be screening, in addition to all people 13 to 64, screening those folks at least once and again on an as-needed basis. We also want to think about those starting treatment for TB. Again, anyone seeking testing and treatment for STIs, of course. And then if you have concerns for an acute HIV infection, and then with each pregnancy for folks who become pregnant. So how are we going to screen these people? The gold standard is a lab-based test, most commonly the fourth-generation antigen antibody test. So this is a blood draw that sends off to the lab, and then the patients will need to follow up for their results. We can use today's diagnostic tests to reduce the time to diagnosis. And so we'll talk about a few different tests and the window period in which they will become positive. It's important to note that no diagnostic test can detect HIV immediately after exposure. And so we have to keep that in mind when screening people and knowing when to bring them back. So let's take a look at that. These are different types of HIV tests and the window period, which again is that time between exposure and when that test would turn positive. So the different tests include nucleic acid test. This would be considered a viral load test, which again, you're going to draw from the blood, send out to the lab. It can detect HIV between 10 and 30 days after a potential exposure. So this is the test that often will be positive first. So if you have concerns for a very recent exposure, ideally we want to run this sort of test. The antigen antibody test is going to turn positive within 18 to 45 days after the potential exposure. Also, a venous blood draw that will be sent to the lab. And so, 18 to 45 days. So if a patient comes in and they were exposed potentially a week ago or 2 weeks ago, we always want to test them, but it's ideal to try and have them come back maybe in 30 days or 45 days just to be sure that they weren't tested during that window period. Another type of test that you might have seen, especially if you've been out in the community or seen, HIV testing fairs, or if you're in like a drugstore and you see those over-the-counter HIV tests, these are often rapid tests, and they can be done with a finger stick and sometimes even a cheek swab. So these ones can take up to 90 days to turn positive. So this is not the type of test that you want to choose for someone who's worried about an acute exposure. It's great for broad screening in the community, and it's a great tool to have on hand. But again, it can take up to 90 days to turn positive. So really emphasizing the need to return and test again in case you get a negative result. Next one. Antiretroviral therapy should be delayed in patients with newly diagnosed HIV until their CD4 count falls to a critical threshold. This is a myth. Current DHHS and WHO guidelines recommend initiating therapy as soon as possible after a diagnosis, regardless of the CD4 count or the viral load. So, rapid start initiation of therapy is the gold standard. It's the standard of care. We do not want to wait for the CD4 count to drop. We don't even want to wait to get those labs back before initiating therapy. So, this is definitely a myth. There are a lot of benefits to this rapid start approach. And so when we start patients on therapy as soon as possible, ideally within the same day as they were diagnosed, it really decreases the time to viral suppression, therefore reducing the risk of transmission to their partners and in the community. So we want to get them to an undetectable status as fast as possible. And this can also improve retention in care. It really can be kind of an empowering thing to know as well. So, when patients come in, this can obviously be very shocking news and upsetting news. But what I find helpful about Rapid Start is that patients can be reassured that we are going to start you on therapy right now. We're not going to wait. We're going to go ahead and start treating you now. So that is often powerful at reducing stigma. We can emphasize that, concept of U equals U. Once you reach this undetectable viral load, you cannot spread the virus to partners. And so, again, rapid start initiation is the standard of care. We want to get people on treatment as soon as possible after that positive test has been confirmed. Next one, treating HIV can be as simple as treating dyslipidemia. This is a truth. Modern HIV therapy has really transformed dramatically. Again, I always tell my colleagues and people that I speak to that treating HIV is no more complicated than treating diabetes or hyperlipidemia, and primary care providers can certainly do it. So, when we think about the history of HIV treatment in the 90s, sometimes, or when we see even, in movies, sometimes people are taking up to 20 pills throughout the day, or, long-term survivors will tell you about how they would keep beepers and timers on them because they had to take handfuls of pills all throughout the day. And that was just as recently as the 90s. So in that amount of time, we have progressed in treatment so much that patients can now take one pill once a day, or they can get injections every 2 months. So it's really just been a drastic improvement in both therapy and the quality of life for these patients. So, when someone is found to have HIV, we always want to be sure and check for co-infections, including hepatitis. So, we're going to be screening for hepatitis B and C in case those patients are not immune to hepatitis B, offering vaccinations, and in case they are found to have hepatitis C, also treating that. Okay, so when someone is found to have HIV, there are treatment initiation guidelines, and we will include these links on the website. So, again, really what we want to emphasize is rapid start initiation. So, if we are starting someone on therapy before the results of drug resistance testing or other baseline examinations have been completed, we can choose one of the following regimens. So, single tablet regimen is often ideal for patients. So, we could choose bictegravir with TAF and emtricitabine. That again is a single tablet regimen, so it makes it quite simple for the patient. Or we could go with dolutegravir plus tenofovir plus emtricitabine or lamivudine. So we do have some options in terms of rapid start. Again, the important thing is that we are starting patients as soon as possible. One thing to know, though, is that if your patient who you are starting on ART has a history of using cabotegravir for PrEP, so the 2-month long-acting injectable for PrEP, ideally, we want to have a genotype resistance test beforehand to determine if that patient has any integrase resistance. And so, for those specific subset of patients, the ideal treatment would be boosted darunavir plus tenofovir plus emtricitabine or lamivudine. So, whenever you are starting a patient on therapy, we want to ask them if they have ever been on cabotegravir for PrEP. We're also going to include a little bit more information on implementing rapid initiation of ART on the website, but just know that we want to initiate as fast as possible with those medications that I just mentioned. It might be important to make sure that they are connected to counseling and payment assistance programs, as these medications can be quite expensive. We're not going to deter therapy while we wait on our baseline testing to come back. And we also really want to make sure that there is a plan in place to keep these patients in care. Next one, patients returning to HIV care after a treatment gap should wait for full lab workup before restarting ART. This is a myth. So similarly to a new start patient, someone who is newly diagnosed with HIV, if your patient has fallen out of care or has been off their medication, we want to restart therapy as soon as possible. We do not want to delay restarting treatment. The longer we delay, the risk of disease progression, opportunistic infections, and transmission to others continues to rise. So again, we do want to try and get some baseline labs, but we do not want to delay their therapy while we wait to get those labs back. So you can consider a restart the same way as a new start. We want to rapidly reinitiate that medication as soon as possible. Next one, ART is poorly tolerated with lots of side effects. This one is a myth. Modern ART is generally very well tolerated. Most patients, again, are on simple once daily regimens or long acting injectables, and there are very minimal side effects. Typically, with modern regimens, side effects are mild, they are transient, and usually resolve within the first few weeks after starting therapy. And so nowadays, the benefit of these regimens far outweigh any concerns about tolerability or side effects. Concern about side effects should not delay initiation. And as a reminder, so if someone who you screened for HIV is testing negative, you want to discuss PrEP. So we really want to have that wraparound care. If they test negative, we are discussing PrEP options. If they test positive, we are going right into treatment options.
Thank you, Asia, for debunking those myths and pointing out the truths about HIV. And thank you for watching. Please check out our fourth and final episode of this year's series, where we explore myths about general medical care and comorbidities in people living with HIV. You can also go back and watch any of the earlier episodes that you might have missed. If you'd like to claim credit, please click the Claim Credit button to take the evaluation. Your thoughts and comments are important and help us develop additional education for MedMythbusters. For CME information, check out mythhiv.dkbmed.com. Did you know DKB Med provides no-cost continuing medical education for clinicians? Well, we do, and you could create a free account if you don't have an account already at dkbmed.com, and you could start earning your free CME and CE credits. See you next time.